Live by Dr. Pat. Leading innovation in fertility excellence.
You know, usually when we talk about a medical diagnosis, there's this expectation of clinical precision.
Right, like it's almost engineering.
Exactly. You
Right.
break your arm, the x-ray shows that jagged white line, and the doctor just points and says, there's the problem.
Yeah, it's very straightforward.
But when you step into the world of advanced reproductive medicine, specifically in vitro fertilization or IVF, the vibe just completely changes. It suddenly feels like you're stepping onto a space station.
It really does. The infrastructure is wild.
Right. We are talking about facilities that require million-dollar clean rooms, tri-gas incubators, massive HEPA filtration systems that are constantly scrubbing the air of these invisible compounds.
It's a modern marvel, honestly,
Yeah.
all designed to artificially replicate the inside of the human body.
But, and this is what we're getting into today, what if you could completely dismantle that million-dollar space-age laboratory, right? And achieve the exact same miracle of creating human life using a setup the size of a shoebox.
Or even better, by just using the human body itself as the laboratory.
Yes. It sounds a bit like science fiction when you first hear it, but this is why you are tuning in today. Our mission for today's deep dive is to explore two revolutionary approaches from a specialist review on low-cost IVF culture systems.
Right, the walking egg and InvoCell.
Exactly.
Yeah.
These two systems are effectively tearing down the traditional, highly expensive architecture of IVF. We're going to dive deep into the hard clinical data to see if they actually deliver on their promises.
Which is so important because, we really need to set the stage and understand the why here.
Yeah, why do we even need to tear down the traditional lab?
Well, if you are listening to this in the US or Europe, IVF is notoriously expensive, sure. But for many, it is still accessible. You can maybe take out a loan or...
Their insurance might cover a portion of it.
Exactly. But for a huge portion of the global population, that is simply not the reality.
Yeah,
The global disparity is just staggering.
it really is.
When we look at low and middle income countries, often referred to as LMICs, the financial barrier is almost insurmountable. To put it in perspective, a single cycle of standard IVF in these regions can cost anywhere between 100% and 200% of a person's annual GDP per capita.
Wait, so we're talking about a procedure that costs up to twice what an average person makes in an entire year.
Yes.
And that's just for one single attempt, right? Which isn't even guaranteed to work.
Exactly. It is a grim reality. By World Health Organization definitions, an expense like that crosses the threshold into what's called a catastrophic medical expenditure.
Wow. Catastrophic.
Yeah, it represents complete financial ruin for families who are just trying to overcome infertility. And, you might think that medical tourism offers a workaround.
Right, like flying to another country to get it done cheaper.
Right. People travel to places like Thailand, where labor and facility costs are lower. But even there, standard IVF, and this is before you even factor in the incredibly expensive medication, it's still running between $4,000 and $7,000 US.
Jeez.
So the core issue here is that the million-dollar clean room is effectively a giant financial wall. It just keeps the vast majority of the global population locked out of reproductive care.
Okay, let's unpack this wall. Because to understand how these new low-cost systems actually manage to bypass that barrier, we need to understand what they are replacing. Like, what makes a standard IVF lab so outrageously expensive to build and maintain in the first place?
Well, it all comes down to environmental control. Human embryos are exquisitely sensitive the moment they are outside the human reproductive tract.
Makes sense.
In nature, an embryo is completely shielded from light, temperature drops, and airborne toxins. The moment you take an egg out of a patient and put it in a petri dish, it is suddenly in a very hostile environment.
Right, so conventional IVF tries to solve this by basically building an artificial fortress.
Hence your space station analogy earlier. Laboratories are built to what is called ISO class 5 to 7 standards.
Which means what exactly?
Well, to visualize that, a normal room has millions of microscopic particles floating in every cubic meter of air. An ISO class 5 clean room forces the air through these massive filters, so there are fewer than 100,000 particles.
Oh, wow.
And they have to scrub out volatile organic compounds, or VOCs.
Like chemicals in the air?
Yeah, these are gases emitted by everyday things, cleaning supplies, perfumes, or even just the paint on the walls. They can be highly toxic to a developing embryo.
That is wild to think about. Your perfume could literally ruin an IVF cycle.
It absolutely can. And on top of that, they use enormous, complex tri-gas incubators to perfectly balance the carbon dioxide and oxygen levels in the air so the liquid the embryo sits in stays at the perfect pH.
And I imagine all that machinery isn't cheap.
Not at all.
Yeah.
Just the capital outlay to build one of these rooms can run anywhere from 200,000 to over €1,000,000. And that doesn't even include the massive energy bills to keep the air handlers running 24/7.
It sounds like an engineering nightmare trying to recreate the perfection of the human body using synthetic materials and like massive HVAC systems, which makes this first simplified system from the review so intriguing.
The walking egg.
Yes, the walking egg, or the simplified culture system. It was developed by Jonathan Van Blurkum and Willem Ombelis. And from what I read in the sources, their approach was to basically look at that massive, heavy tri-gas incubator and replace it with a simple, closed-tube chemical generator.
That's right. They essentially shrank the environment. They used 2 standard medical-grade glass tubes. They look almost identical to the tubes a phlebotomist uses when they draw your blood.
Okay, so just basic glass tubes.
Exactly. One of them is the culture tube. This is where the liquid medium sits and where the embryo will eventually grow. The other is the generator tube. Inside this generator tube, they place dry citric acid and sodium bicarbonate.
Citric acid and sodium bicarbonate.
Yep. You add a specific amount of sterile water, seal it, and it generates carbon dioxide gas.
Wait. I remember reading the chemical formula in the source material. It's C6H8O7 plus sodium bicarbonate. That is literally just citric acid and baking soda.
It is.
Are we talking about the exact same chemical reaction that kids use to make those, like, papier-mâché volcanoes erupt at a middle school science fair?
Yes, it relies on the exact same underlying chemistry as the science fair volcano.
That is mind-blowing. How does a baking soda volcano replace a $1 million incubator?
Well, it's applied with absolute stoichiometric precision.
Stoichiometry.
Yeah, stoichiometry is just the math of chemistry. It's calculating the exact ratio of ingredients so you know precisely how much product you'll get. When the embryologist adds the water, the citric acid and sodium bicarbonate react and liberate a very specific, mathematically predictable volume of carbon dioxide gas.
Okay, so instead of buying a massive tank of CO2 from a medical supply company, you're brewing it on the spot. But how does the gas actually get to the embryo?
The 2 glass tubes are connected by a short, thin piece of catheter tubing.
Got it.
The generated CO2 pushes through that tubing and enters the culture tube, displacing the normal room air out through a tiny vent.
Oh.
Once the room air is pushed out, you just seal it.
Oh, clever.
And overnight, that trapped carbon dioxide perfectly equilibrates with the liquid medium. It stabilizes the pH of the fluid to exactly 7.29 to 7.35, which is the perfect sweet spot for an embryo.
And for heat.
Instead of massive heated chamber, you just slide this glass tube into a simple low-wattage aluminum block that keeps it warm at a steady 37 degrees Celsius.
But wait, if you are just mixing chemicals in a glass tube and keeping it warm on a metal block on, like, a standard desk, aren't you bypassing all those HEPA filters and VOC scrubbers we just talked about?
You are.
So how do you keep airborne microbes or toxic perfumes from contaminating the fluid if you don't have a clean room?
Well, you don't need to scrub the room air because the room air never actually touches the embryos. The entire system is completely closed. When the embryologist goes to introduce the gametes, that's the human egg in a droplet containing about 10,000 motile sperm, they don't open the tube. They inject them directly through a rubber septum at the top of the tube using a fine needle. When they pull the needle out, the rubber instantly seals itself back up.
Oh, that makes so much sense. The glass wall of the tube essentially becomes the clean room?
Exactly.
Yeah.
It functions as an impenetrable physical barrier. Airborne particulates, volatile organic compounds, microbes, they just bounce off the glass.
That is incredible.
And there's a fascinating biological advantage here, too. In a traditional $1 million lab, the embryos sit in petri dishes inside a large incubator. Every time an embryologist opens that heavy metal door to check on another patient's embryos, room air rushes in.
Right, which messes up the environment.
Exactly. The gas levels fluctuate, the temperature drops slightly, and it takes the machine several minutes to recover. But with the closed glass tube of the walking egg, you can pull it out of the heat block, look at it under an inverted microscope, and just put it back. The gas phase inside the sealed tube remains completely undisturbed.
So you're actually getting a more stable environment while shrinking a multi-room facility down to the footprint of a shoebox. That is brilliant.
It really is an elegant solution.
But that is just the first system we're looking at. The second one, called Ein Velo Cell, takes a completely different route because instead of shrinking the laboratory into a tube, it just uses the laboratory that nature already built.
Yeah, the INV cell system is a marvel of bioengineering, and the initial concept has actually been around since the late 1980s.
Really? That long?
Yeah, but modern plastics have made it commercially viable today, spearheaded by researchers like Duty and his colleagues. The core idea is that instead of spending a fortune trying to replicate the human reproductive tract, we just use the vagina as a natural bioreactor.
It's such an elegant pivot, right? Like, we spend all this money on artificial heaters and synthetic medical gases, but the human body's natural capillary perfusion, like the blood flow in the tissue, is constantly maintaining a perfect 37 degrees Celsius anyway.
Exactly.
And I also read in the notes that the natural oxygen level inside the reproductive tract is about 5%, whereas atmospheric room air is at 21% oxygen, which creates those toxic free radicals that can damage embryos. So the body already has the perfect gas mix.
It does.
How do they actually harness that, practically speaking?
The mechanics are remarkably straightforward. The modern INV cell device is a small, gas-permeable polymer chamber. It's tiny, about 3 by 4 centimeters.
Okay, so very small.
Very small. Inside this inner chamber, the doctor places up to 7 eggs and the sperm in less than 1 milliliter of culture medium, covered by a tiny bit of protective oil. This chamber is then placed inside the posterior fornix of the vagina, which is the space right up against the cervix. It's held securely in place by an outer retention device, which looks and functions very much like a standard contraceptive diaphragm.
So the patient literally walks out of the clinic, goes home, and incubates their own embryos while going about their daily life.
They do.
Yeah.
Because the plastic of the inner chamber is gas permeable, the carbon dioxide levels inside the fluid equilibrate naturally with the gases in the vaginal mucosa.
Wow.
It automatically maintains that pristine pH level without any chemical generators or heavy machinery. The device stays in place for 3 to 5 days.
And then what?
After that incubation period, the patient comes back, the device is retrieved, the embryologist looks at the embryos under a microscope, selects the healthiest one, and transfers it directly into the uterus.
Okay, so if I'm a prospective parent looking at this, my first thought is definitely going to be about quality. Cost is a massive barrier, absolutely, but having a healthy baby is the ultimate goal, right? So if we bypass the high-tech clean room, are we sacrificing safety? Does a shoebox lab or a plastic chamber actually work as well as a multi-million-dollar facility?
It is the most critical question in the entire review, honestly.
Yeah.
And the clinical data is highly reassuring.
Okay, let's hear it.
Let's look at the walking egg first. The decisive evidence for this system comes from the GANK sibling oocyte program, which looked at 653 treatment cycles.
And for anyone unfamiliar, a sibling oocyte study is basically the ultimate A/B test in reproductive medicine. You take eggs from the exact same patient during the exact same cycle and you split them.
Right.
Half go to the million-dollar lab and half go into the shoebox glass tube. It completely eliminates all the genetic and age-related variables between different patients.
Is the gold standard for comparing lab environments. And the results were remarkable. The simplified tube didn't just match the high-tech lab in one key metric, it actually outperformed it. Yes. The fertilization rate for the walking egg was 61.1%. The control group used ICSI, which is a highly technical method where a single sperm is physically injected into an egg using microscopic needles. And that fertilization rate was only 50.4%.
Wow, so 61% versus 50%. That's a noticeable jump.
It is. Furthermore, the ongoing pregnancy rates were statistically equivalent, 32% for the low-cost tube versus 36.7% for the standard lab.
That's a huge validation for the chemistry. But what about the actual health of the babies once they're born?
What's fascinating here is that the safety data is perhaps the most impressive part. When researchers analyzed the perinatal outcomes, which measures the health and safety of the infants around the time of birth, they found no disadvantages.
That's amazing.
To get a broad picture, they compared the babies born from the Simplify system to the massive Belgian National Registry of all conventional IVF babies. And the rate of premature birth was actually significantly lower for the simplified system.
Wait, really? Lower?
Yes. It was 3.8% for the walking egg, compared to an average of 10.2% for standard IVF in the registry.
Why do you think that is? Could it be that the embryos are handled less, so there's just less stress on them overall?
That is a leading hypothesis. By keeping the embryo in a stable, closed glass tube without constantly opening an incubator door to check on it, you minimize temperature and pH fluctuations, which reduces cellular stress. Now, the data for the INVO cell system shows a slightly different nuance.
Okay, how so? Does the body incubator fall short of the lab?
Well, in InVioCell's pivotal clinical trial, they measured something called the blastocyst yield. A blastocyst is an embryo that has successfully developed to day 5, forming a complex structure of about 100 cells.
Right, it's essentially a survival of the fittest milestone for the embryo.
Exactly. In a direct comparison, the blastocyst yield was actually lower for InViocell. It was 30.7%, whereas the conventional lab produced a 50.6% yield.
Oh, I see. So the traditional lab is better at sheer numbers. It forces more embryos to reach that day 5 finish line.
It does. The highly optimized artificial lab environment might be slightly more forgiving than the natural fluctuations of the body. However, there is a critical caveat here.
Which is?
The blastocysts that did successfully reach day 5 in the INV cell were of incredibly high quality. Because they were so robust, the final live birth rates, the metric that actually matters most to a patient, did not differ significantly.
Okay, what were the numbers?
The live birth rate was 55% for INVO-cell and 60% for conventional IVF. That equivalency in live births is what ultimately earned INVO-cell its clearance from the FDA in the United States.
That makes perfect sense. The body might be a slightly tougher environment, so you get fewer embryos overall, but the ones that survive the journey are incredibly strong and just as capable of resulting in a healthy pregnancy.
Exactly.
So the biology is sound, the safety data is there, but if we are really talking about democratizing global health and dropping the price tag, we have to look at the economics. Where do the massive savings actually come from? Because it can't just be saving electricity on an incubator, right?
No, the incubator is just one piece of the puzzle. The cost savings come from an integrated package. You see, these simplified culture systems are paired with what's called a mild stimulation protocol.
Right. To contrast that, a standard IVF cycle usually uses high-dose ovarian stimulation. The patient takes daily hormone injections to force the ovaries to produce a massive crop of eggs, sometimes 15 or 20 at once.
Yeah, the rationale has always been that since the lab attrition rate is high, you want to farm as many eggs as possible to guarantee a few good embryos.
But those drugs are notoriously expensive, right?
Yeah.
And physically exhausting.
They are very tough on the body. The stimulation drugs are actually the single largest pharmacologic cost driver in all of assisted reproductive technology. It can cost thousands of dollars just for the medication.
Jeez.
It also requires constant monitoring. Patients have to come into the clinic every few days for transvaginal ultrasounds and blood tests to make sure they aren't developing ovarian hyperstimulation syndrome, which can be dangerous.
So how does mild stimulation change that whole process?
Both the walking egg and InvoCell protocols use less than 150 international units per day of gonadotrophin hormones. Instead of aiming for 20 eggs, the goal is to target just 8 or fewer high-quality oocytes.
Bro, that's a huge difference.
Because the hormone dose is so low, the risk of hyperstimulation practically disappears. That means you need minimal ultrasound monitoring and far fewer blood tests. The clinical overhead drops massively.
And when you combine those medication savings with the simplified lab...
Exactly. The walking egg system drops laboratory consumable costs down to under 200 euros per cycle. So the total cost of a full IVF cycle plunges to somewhere between $500 and $2,000.
200 euros for the lab supplies. That is basically a rounding error compared to traditional IVF.
It really is.
If the whole package drops from over $10,000 down to $1,000, it really could change the world. But, you know, whenever something seems too good to be true in medicine, there's usually a catch.
What are the limitations here? Can anyone struggling with infertility just sign up for a shoebox lab procedure? That is the hard reality we have to address. The patient limitations are strict. These systems are highly effective, but they are designed for a specific cohort, what we call normoresponsive women.
Okay, meaning what exactly?
Generally, that means women under the age of 43 or under 38 for the INVO-cell protocols who still have good ovarian reserve.
And ovarian reserve is usually measured by a blood test looking at AMH, right?
Correct. AMH stands for anti-Müllerian hormone. You can think of it as a fuel gauge for the ovaries. It gives doctors a rough estimate of how many potential eggs a woman has left. To qualify for these low-cost systems, a patient generally needs an AMH level above 0.8.
And if they don't have that?
If a patient has a very low AMH, or they are dealing with advanced maternal age, their ovaries simply won't respond well to the mild stimulation protocols. They often require the high-dose drugs to retrieve even 1 or 2 eggs.
So it's not a silver bullet for age-related infertility.
It isn't. But perhaps the biggest bottleneck is that these simplified systems entirely exclude severe male factor infertility.
Wait, why does male factor infertility break the model? If you have an egg and you have sperm and you put them together in the glass tube, why doesn't it work?
Because if a male patient has a very low sperm count or poor sperm motility, meaning the sperm can't swim properly, you cannot just put the gametes together in a tube and wait for nature to take its course. The sperm physically cannot penetrate the outer shell of the egg on their own.
Oh, I see.
You have to intervene mechanically. The embryologist has to isolate a single healthy-looking sperm, draw it up into a microscopic glass needle, and physically inject it directly into the egg. That procedure is called ICSI, or intracytoplasmic sperm injection.
And let me guess, you can't perform microscopic sperm injections on a standard desk with an aluminum block.
Not at all. To perform ICSI, you need a highly skilled embryologist sitting at a specialized workstation called a micromanipulator. A medical-grade micromanipulator costs upwards of $80,000 US.
Wow.
Furthermore, because you are dealing with movements at a cellular level, the microscope has to sit on a heavy, expensive anti-vibration table so that even the rumble of a truck driving down the street doesn't cause the needle to shred the egg.
That is insane.
So the moment a couple needs ICSI to overcome severe male factor infertility, the capital savings of your simplified shoebox lab instantly vanish. You're right back to needing expensive, non-portable, highly technical infrastructure.
So what does this all mean? We have to look at this realistically. This technology is not a total replacement for high-end reproductive medicine.
Right.
If a family needs advanced genetic testing on their embryos to prevent an inherited disease, or if they have severe male factor infertility, they still need the million-dollar lab. But for the massive demographic of patients dealing with unexplained infertility or tubal factor infertility, this is an incredibly powerful, accessible first-line tool.
Absolutely. It targets a huge portion of the population that just needs a little bit of biological assistance to get started.
Which leads to a really frustrating question. If this technology works beautifully for a specific cohort, and it's clinically proven, and it can prevent financial ruin for families all over the world, why isn't it available at every single local clinic right now?
It comes down to a very harsh economic reality. The source material outlines the sheer scale of the market disincentive. The global assisted reproductive technology market was valued at $34.7 billion in 2023. By 2033, it is projected to practically double, reaching $62.8 billion.
That's a massive industry.
Exactly. The established high-end providers have immense financial disincentives to introduce low-margin, simplified systems into their business models.
It's the classic innovator's dilemma. If a clinic has already spent $2 million building a pristine ISO clean room, and they can successfully charge $20,000 for a conventional cycle, why on earth would they introduce a $500 glass tube alternative? They would instantly cannibalize their own revenue stream.
Precisely. Dr. Willem Amble, the pioneer of the walking egg, has been on a relentless 15-year advocacy campaign to get this adopted globally. And as the review bluntly notes, his team reports that interest from the industry and from healthcare managers remains remarkably low.
That is just depressing.
And beyond the pure economics, there are also significant regulatory hurdles to getting these systems deployed.
What kind of hurdles? You mentioned earlier that InvoCell has FDA clearance.
Yes, InvoCell navigated the regulatory maze successfully because it is a manufactured, standardized medical device. It's a physical product you can patent, test, and put in a box. It has FDA clearance in the U.S. and a CE mark in Europe. But the walking egg is different.
How so?
It isn't a proprietary machine. It is a procedural method that utilizes generic, off-the-shelf laboratory parts. Regulators really struggle with how to approve a recipe. You can't easily patent or standardize a protocol of using basic blood draw tubes and common chemicals across different national borders.
So it's caught in this bizarre catch-22. It is almost too simple and too cheap for massive corporations to want to sell it, and it's too unstandardized for international regulators to easily rubber stamp it.
That is the core of the problem. But if we connect this to the bigger picture, this technology actually opens up a massive geographic opportunity for the future of global health. The source review points to a proposed hub-and-spoke model, specifically looking at places like Thailand.
The hub-and-spoke model, walk us through how that would change the landscape.
Well, Thailand already has an incredible medical tourism infrastructure centered in Bangkok. They have massive high-tech tertiary care centers. Those are your hubs. They have the $80,000 micromanipulators, the vibration tables, and the genetic testing labs.
Right.
But instead of forcing every single patient to travel to Bangkok, take weeks off work, and pay exorbitant fees, you build a network of spokes.
Yeah.
You place these low-cost, shoebox-sized walking egg labs in small, rural satellite clinics across Thailand, or even in neighboring regions like Cambodia and Laos.
So a patient goes to their local rural clinic. They try the low-cost, basic IVF first. If it works, amazing. They saved thousands of dollars and stayed close to home.
Exactly.
But if the local doctor discovers a complex issue, like severe male factor infertility, they simply refer the patient inward to the high-tech hub in the city.
It democratizes access immediately without needing to tear down the existing high-end infrastructure. It creates a logical, tiered medical system. And we are already seeing proof that this extreme decentralization works. In mid-2025, the very first babies were born from a fully mobile, container-based walking egg unit operating in rural South Africa.
Are you serious? A shipping container?
Yes. They literally packed the entire central laboratory into a standard shipping container, put it on a truck, and brought the medicine directly to the patients.
That is genuinely profound. Think about the arc of what we've discussed today. We started with a $1 million architectural marvel that people have to fly across the world to access. And we end with a shipping container in rural South Africa, or a tiny plastic chamber that a patient literally carries inside their own body.
It is a total paradigm shift.
It really is. It proves that while we have built incredibly complex environments to try and replicate biology, biology itself is remarkably resilient. If we just understand the underlying mechanism, the exact pH, the precise temperature, we can safely guide the spark of human life with a few basic chemicals in a glass tube.
It strips away the unnecessary complexity and reminds us that at its core, this is a biological process, not an industrial one.
And that leaves us with one final thought to mull over. We spent a lot of time today talking about the clinical data, the blastocyst yields, and the macroeconomics. But there is a brief, fascinating mention in the research regarding patient satisfaction with the INVO cell system. The authors pointed to this concept of active participation psychology. When a patient undergoes conventional IVF, their embryo is locked away in a distant, sterile laboratory incubator. They just go home and anxiously wait by the phone for an embryologist to call with updates.
It can be a very isolating experience.
But with a system like INV Cell, the patient is physically incubating their own embryo inside their body from day one. They are the laboratory. As this technology spreads, you have to wonder how that active physical participation might permanently redefine the psychological and emotional experience of assisted reproduction for future parents. Could the future of IVF be not just vastly cheaper and more accessible, but deeply biologically more intimate? Something to think about. Until next time.
Leading innovation, fertility, excellence. Live by Dr. Pat. Leading innovation in fertility excellence.